Hello, everyone. My name is Emily Hoppus, and I'm a technical officer in the product development and introduction team at FHI 360. I'm excited to welcome you to our session today titled Contraceptive-Induced Menstrual Changes, a Call to Action. I'm joined today by a wonderful panel of experts who will be taking us through this session. An introduction to the topic will be presented by Funmi Olorun, who is, among many other things, part of the Evidence for Sustainable Human Development Systems in Africa organization, and she's joining us from Nigeria. We will then hear about some of the user preferences research and evidence related to contraceptive-induced menstrual changes, which will be presented by Chelsea Polis from the Guttmacher Institute and Simon Hibira from Makerere University. Finally, my colleague Amelia McKenzie, a scientist at FHI 360, will join me to present a global call to action and research agendas for the issue of contraceptive-induced menstrual changes. So, Funmi, I'll hand it over to you to begin.
Thanks, Emily. Hello, everyone. It's a pleasure to be able to give a brief introduction. Next slide, please. I'd like to share a very brief and general introduction to contraceptive-induced menstrual changes, or CIMCs. The term encompasses a range of possible changes that individuals experience when using different family planning methods. And these changes will vary from one user to another, and they include changes in the duration, the volume, the frequency or the predictability of the bleeding, changes in the consistency of the blood, changes in uterine cramping, and changes in pain. There could be changes over time with continued use of a method. There could be changes to the menstrual cycle after discontinuing a method. And there could be other changes in symptoms that are associated with menstruation and other phases of the menstrual cycle, such as migraines. Next. Depending on your discipline and your background, you may use or have encountered various different terminologies to talk about what we've termed contraceptive-induced menstrual changes. The word cloud that you can see on the screen was created from terms that we've seen used to refer to CIMCs in whole or in part, and you can see how varied these are. Next. So why should we care about CIMCs? We know that CIMCs can negatively impact the lives of users, resulting in consequences, or it can have a positive impact on their lives, bringing about opportunities. An estimated 218 million women of reproductive age between 15 and 49 years of age in low and middle income countries have an unmet need for modern contraception. That is, they want to avoid a pregnancy, but they're not using a modern method. And many of these women have method-related reasons for not using, and this makes CIMCs a very important issue to address. CIMCs can impact users' lives, not just in negative ways, but in positive ways as well, bringing about opportunities. Unfortunately, the family planning and menstrual health fields have often not adequately incorporated considerations about CIMCs into research, programs, policies, or even program development. Next, please. Perceptions or experiences of CIMCs vary from woman to woman and even across populations. These perceptions and experiences may be related to social norms surrounding fertility, contraception, menstruation, as well as women's personal preferences. When women experience undesirable CIMCs, consequences may include those related to their use of family planning or their quality of life. With respect to their use to family planning, some of the consequences of undesirable CIMCs include dissatisfaction, discontinuation, switching, but unfortunately to a less effective method, inconsistent use, and non-use. And with respect to the quality of life, some of the consequences include physical, emotional, or economic impacts on their quality of life, mental burden. Some of them have disapproval from their partners or from members of their family. And there is need for more or different menstrual health materials. Next. We must always look for the silver lining. Some women may find CIMCs desirable, thus providing potential opportunities for public health researchers and program planners to explore. For instance, health benefits include the treatment of menstrual disorders, such as with oral contraceptive pills. I've had patients in the past expressing their gratitude for oral contraceptive pills that help them to regularize their otherwise irregular periods. Where a condition like anemia is a concern for a woman, contraceptive pills or hormonal IUS can be beneficial in reducing blood loss. There are also potential lifestyle benefits, such as the freedom to engage in daily activities when menstrual flow is more predictable or amenorrhea is experienced. I've also had patients who reported both reduced menstrual flow and amenorrhea as beneficial experiences for the respective lifestyles that they live. Another benefit linked to reduced menstrual blood flow or amenorrhea is the cost savings made on menstrual hygiene materials. Next. As I've already alluded to, there are potential non-contraceptive health benefits of some hormonal family planning methods, and these include improved menstrual regularity, reduced menstrual cramping and/or pain, and treatment or reduction in the symptoms of menstrual disorders and menstruation-related diagnoses. Also, reduced risk of iron deficiency anemia. So we can see that there are opportunities that can bring about ways in which we can think about CIMCs differently as well. Now I'd like to hand it over to Chelsea.
Thank you, Dr. Ola Arun, and thanks to all of you for joining. I'm really happy to be part of this panel and to have a chance to present this work on behalf of my co-authors. Next slide. So today I'm going to be summarizing a scoping review that we published in the journal Reproductive Health on women's responses to contraceptive-induced menstrual bleeding changes, or what we called CIMBCs, as kind of a subset to the broader umbrella term CIMPs that encompasses more than just the specific changes to bleeding. We've known for a long time that side effects and health concerns broadly are leading reasons for non-use or discontinuation of contraception among women who do not desire pregnancy. And as noted earlier, certain methods like hormonal methods and copper IUDs can cause CIMBCs. Perceptions around CIMBCs can be rooted in personal experience, in knowledge of other people's experiences, or in misinformation. And cultural norms and values may really shape the tolerance or lack thereof for CIMBCs. So how people interpret CIMBCs might impact their willingness to try or to continue using a given method. And differences exist between the bleeding patterns that someone prefers and that someone is willing to tolerate in exchange for the benefits of contraceptive effectiveness. Typically, when large nationally representative surveys have asked about reasons for contraceptive non-use and discontinuation, they've used very broad response options such as health concerns, fear of side effects, things like that. And this has precluded researchers from really determining how much specific side effects like CIMBCs have impacted those outcomes. And then another factor to consider is that some response options such as self or partner opposition might stem from beliefs that pertain to side effects like CIMBCs. So really understanding responses towards experienced or anticipated CIMBCs could have major implications for contraceptive use patterns and for the development of future products. Prior to the scoping review that I'll present, we were unaware of any other scoping review that had examined the extent and range of research on this topic. Next slide. So for the sake of time, I won't delve into our methodology. It's in the published paper, but very briefly, we systematically searched the literature and included relevant peer-reviewed studies from any country published within 15 years of our search. We searched over 1,000 references and included 100 studies that were published between 2002 and 2016. And I'll just quickly note that a substantial proportion of the relevant studies came from Europe, Northern America, and other higher income settings. And so studying these issues in other regions, including Africa and Asia, is particularly needed. Next. We grouped our findings into 5 main themes. Key theme 1 focused on women's responses to contraceptive-induced amenorrhea and other non-standard bleeding frequencies. Women's responses varied widely across individuals and regions. So for example, in some multi-country surveys that were done, preferences for amenorrhea ranged all the way from 0% of women in Tunisia to 65% of women in Brazil. Generally, amenorrhea seemed most acceptable in North America, Europe, and South America, where positive views of amenorrhea centered around convenience or avoidance of menstruation-associated problems like painful periods. But elsewhere, amenorrhea was often viewed negatively, with many women feeling suspicious of it, seeing it as a disadvantage of hormonal contraception, and identifying menstruation as a natural state of womanhood. Next slide. A second theme was CIMBCs as a reason for non-use, dissatisfaction, or discontinuation. And while I don't have time to walk through the detailed results on each of those categories, in general, multiple studies reported that CIMBCs, and in particular, irregular, heavy, or prolonged bleeding, were top reasons for contraceptive dissatisfaction and discontinuation. And while other studies suggested that disruption of regular bleeding patterns was associated with non-use. Some studies showed that despite dissatisfaction of specific aspects of a given method, some users may nonetheless choose to continue use and kind of put up with those side effects. Next slide. Our third theme was conceptual linkages between CIMBCs and health risks or other side effects. So even while regular menstruation is viewed by many people as a marker of health and fertility, there's a great deal of stigma that surrounds menstruation and menstrual blood itself. Some people view menstrual blood as dirty, leading to a belief that it must come out every month so that the body can be cleansed. So they may then interpret contraceptive-induced amenorrhea as dirty blood building up in their body and leading to things like cancer, bad skin, fibroids, or a range of other health outcomes. For some people, amenorrhea calls into question the effectiveness of their contraceptive method. And yet others interpret amenorrhea as a blockage of blood that risks suddenly rushing out all at once, leading to immediate death. IUDs can increase the amount of menstrual blood, and some believe that this extra blood loss will cause them to become infertile. So while some of these pathways are not supported by biomedical evidence, it drives home the importance of understanding the meanings that people ascribe to bodily functions like menstruation. And without understanding those perceptions, we can't fully understand contraceptive acceptability or provide appropriate counseling. Next slide. I'm going to just briefly mention theme 4 for time, women's responses to deliberate menstrual suppression, and to say that a very wide range of participants across studies had ever tried this, and suggest reading the paper for more detail on that. Next slide. CIMBCs can have truly profound impacts on domestic, work, school, and religious life. For example, one study noted that in Bangladesh, women are prohibited from praying, having sex, performing certain household tasks, or participating in community activities during menstruation. And since women are expected to do these activities in this context, this can create a tension, which certain contraceptive methods can exacerbate by prolonging menstruation. So multiple Bangladeshi women in this study reported IUD discontinuation, and that wasn't because they didn't report liking the method, but because of how CIMBCs impacted their lives, in some cases, even exposing them to domestic violence. In Mali, several women described how excessive bleeding led their partners to seek extramarital partnerships, increasing the risk for those women of STIs and HIV. CIMBCs can also have major implications on other dimensions of people's lives, so healthcare providers really have to take people's concerns about CIMBCs seriously. And when providing information on potential or expected side effects, including CIMBCs, it's a recommended, while providing this information is a recommended component of comprehensive contraceptive counseling, our search strategy in the review identified few studies that actually measured the impact of counseling on method satisfaction or continuation. So that's something to do a little bit more digging into. Next slide. And so just briefly, our paper goes into detail on recommendations that stem from our scoping review. For example, we suggested that nationally representative surveys include more specific response options to enable more precise quantifications of the impact of CIMBCs. And it's thrilling that the most recent revision of the DHS questionnaire did make this change. So this, there should be more data on this coming out soon. As noted earlier, contraceptive providers must take people's concerns about CIMBCs seriously, given their potential for profound impacts on multiple areas of their lives. Development of new contraceptive or MPT products hold promise from a public health perspective, but the actual impact could be inhibited if acceptability and consequently adherence to the method is not adequately addressed. So studies on responses to CIMBCs within regions that might be chosen for rollout of new products might be useful to enhance product acceptability. And of course, provision of clear information about expected CIMBCs for new products can help people anticipate and manage changes and help avoid negative perceptions from becoming associated with new products. So overall, how people perceive and respond to CIMBCs has been historically underappreciated, despite likely and potentially substantial impacts on key issues like contraceptive discontinuation and non-use. Researchers, providers, product developers, policymakers, service delivery suppliers, and funders can use this body of knowledge to better ensure that people have options that align with their preferences and offer an array of contraceptive profiles, including those that have users' preferred bleeding patterns, so that contraceptors users don't need to tolerate undesirable product characteristics in order to use effective pregnancy prevention methods. So thanks very much, and I will turn things over to my colleague, Dr. Simon Kabira.
Thank you so much, Dr. Chelsea. As introduced, Simon Chibira from the School of Public Health at Makerere University. I'll be taking you through experiences of CIMC from the Ugandan context, and this is looking at a few studies as I will be quoting through. Next slide. Yeah, so this first part of the presentation is from work that we've done in 3 countries in Sub-Saharan Africa. That's Uganda, Nigeria, and Ethiopia. But I'm picking out a bit of results from the eastern and central part of Uganda. And in these studies, we've seen that women reported bleeding changes as undesirable effects of contraception, but most especially those that are related to increasing the flow or extended the duration of the period. And some women reported consequences of contraceptive-induced menstrual changes, including worry about their partners having extramarital sex when their periods are prolonged. And also, there is also an implication on the financial aspects of the women's lives, where they have to spend a little bit more for extra sanitary pads or material during the prolonged and heavy flow of their period. And remember, this is in a population that is already struggling with obtaining sanitary wear as basic material. Many women are also living with unsupportive partners in large parts of the country, and many of the men are objecting to use of contraception. In fact, we have so many women who are using methods without the partner's knowledge. And so contraceptive-induced menstrual changes, especially those that prolong the duration and the flow of the period, become a challenge because they may open up women's clandestine use of methods. And when the side effects like this become visible, it is hard for women to hide their use of contraception, which they intended in the first place. So it's possible that these contraceptive-induced menstrual changes may actually lead to discontinuation of methods, as we shall see later in the presentation. Also, in our setting here and in this research that we conducted, many covert users of methods have expressed the need to have considerable methods that they are able to use, and there's to have a wide range of these methods. But also we know that the most commonly used considerable methods in this part of the world, of the country, Uganda, are basically hormonal methods, including injectables, especially actually injectables. And so if these are going to blow up women's clandestine use, then it becomes a challenge. Next slide. We also noted further from this same study that the interference with the natural body processes may clash with several beliefs that may be existing, that are existing in the several parts of the country. In this particular study, especially in the eastern and central part of the country. There's uncertainty, of course, about where the blood that is retained goes, as my colleague presented before. And so in cases of complete amenorrhea, this is going to be a challenge. However, we noticed that amenorrhea induced by methods actually has been found welcome for women who have troublesome menses, even amidst the beliefs about where the blood goes. And in another study that is already published in PLOS One, which is from a study in potential user interest in new long-acting reversible contraceptive methods in Burkina Faso and Uganda, we found that less bleeding was also perceived as a desirable effect of contraception. Therefore, contraceptive-induced menstrual changes need to be well differentiated because the perception of each of the changes are unique and are context-specific. Next slide. And lastly, in a more recent nationally representative survey in Uganda, which is longitudinal, we found that 1/3 of hormonal contraceptive users reported at least one side effect. And interestingly, the side effects that are most reported were menstrual changes, with women reporting that they bled less or bled more, and oftentimes bled irregularly, or even all three together on varied periods. We found that contraceptive-induced menstrual changes did actually influence contraceptive discontinuation among women, specifically bleeding more or bleeding irregularly, were both associated with a higher risk of discontinuation. We saw relative risk ratios as high as 2 and 1.8 respectively for bleeding more and irregularly. We also found that women who experienced overbleeding were more likely to hold completely the use of contraception as opposed to just switching to just a less effective method. This is worrying because we are in a country where the unintended pregnancies hover around 2 in 5 pregnancies that are happening, and that is quite a high number. So if you have methods that are going to, bleeding changes that are going to cause a discontinuation, that adds to the problem. It also underscores the importance of contraceptive-induced menstrual changes in probably increased non-use of methods in the country. But what is encouraging also from this longitudinal study is that bleeding less was not associated with an increased risk of discontinuation or even switching. So further emphasizing what we saw in the qualitative multi-country study, that less bleeding was actually a desirable effect of contraceptive-induced, a desirable effect of contraception. Next slide. Yeah, so as a takeaway, menstruation that comes with menstruation comes with challenges for women, certainly, and so research needs to take care of this, and accessing a safe material, very good quality material, and safe spaces for changing of this material, balanced with work, and for working women and who are staying at home but also going to work is important. And also building acceptability, certainly for amenorrhea-induced contraception or reduced flow may be easier, but also context-specific. We also note that it's important to consider specific side effects uniquely, as I said, because these are varied depending on the economic and cultural settings. Next. Next. Yeah, thank you. So I'll hand it over to Emily to take you through the next presentation.
Thank you so much, Simon. So as we've heard from our presenters so far, the issue of CIMCs is complex, multifaceted, and impacts users' lives in both positive and negative ways. And it's for this reason that FHI 360, with support from USAID, hosted a technical consultation on CIMCs in November of last year. That meeting included a lot of amazing presentations and discussions, including from our panelists today. But it became evident from that meeting that there's a lot more work to be done, which is why FHI 360 and our partners have been developing a call to action for the family planning and menstrual health communities when it comes to CIMCs. So at the core of this call to action are 4 research agendas organized under these larger domains that you see on the slide. First is a research agenda for measurement. Second, for biomedical and contraceptive R&D. Third, for socio-behavioral and user preferences, which relates closely to what you've been hearing from our presenters today and which we'll go into more detail later. And then finally, a programmatic research agenda. The call to action also includes a measurement framework with a list of indicator categories, as well as a checklist that provides key recommendations for service delivery to address CIMCs. And then finally, the research agenda and other components of the call to action are underpinned and were created using several theoretical lenses. This includes the socio-ecological model as well as a life course approach. And then additionally, the issue of equity has been woven throughout the research agenda and the call to action. So after that quick overview, I'll pass it now to Amelia to provide a more in-depth look at one of the research agendas in the call to action.
Thanks, Emily. So within these 4 domains, we focused on recommendation areas for research, and within each recommended area, a series of more specific research questions. And we don't have time to go into the recommended areas and research questions for each of these domains, but I'll show you a list here briefly before we dive into the social behavioral and user preferences domain to give you a sense of the breadth and depth of these research agendas, and then also to highlight that each include an area focused on integration, either across disciplines or into policy and practice. Next. So for the measurement domain, for example, we've recommended a focus on current frameworks and indicators, advancing development of new ones, and that integration piece shown in the dark red here across all domains. For the biomedical and contraceptive R&D domain, things like understanding the biological mechanisms, prevention and treatment, prediction of menstrual changes, treatment and management of menstrual disorders. I'll discuss the social, behavioral, and user preferences domain next in detail, but for the program domain, things like developing models for effective family planning and menstrual health integration, education and counseling on menstrual changes, including through a self-care lens, digital tools, and more. Next. So for that social, behavioral, and user preference domain, the research agenda is focused on 5 recommended areas. First, understanding experiences of and perceptions and attitudes towards menstrual changes, which we've talked a little bit about today. Second, then understanding what influences those perceptions and preferences. Third, identifying and measuring the many impacts of menstrual changes, both good and bad. Fourth, understanding the relationships between menstrual changes, and then wider menstrual health and family planning experiences and norms. And fifth, again, that integration piece, looking at how we can best integrate research across disciplines and domains. Next. So within these 5 recommended areas of research, here are a few examples of some specific research questions. So which types of menstrual changes do users generally consider to be desirable? Which types do they generally consider to be undesirable? How does this differ by context and other factors? How do perceptions of menstrual changes relate to broader sociocultural norms about things like gender, menstruation, and sexuality? Again, we've heard a little bit about that today. And importantly, how do they influence one another? How do perceptions of different types of menstrual bleeding changes affect contraceptive use dynamics? Again, we've chatted a little bit about that. And so for things like how does lighter bleeding in volume, but that may be more unpredictable, that users may experience with some progestin-only methods, impact things like method uptake, continuation or discontinuation, decisions about method switching, non-use, etc. And how is this different or similar for things like pause bleeding or amenorrhea, or things like increased bleeding? And then back to that integration piece, what are the best practices for communicating and integrating user preferences research findings into other research domains, but also into policy and programs for both family planning and menstrual health? So how can we best take these future learnings from this social behavioral research agenda and share and disseminate and integrate it into this work to better address menstrual changes in research, policy, and programs? And with that, I'll hand it back to Emily to wrap up the session with a few questions for you, the wider community.
Thanks so much, Amelia. So this call to action and research agendas on contraceptive-induced menstrual changes is still under development. And we'd really like to hear feedback from those working in family planning, in menstrual health, and the wider reproductive health community, specifically about which areas of the research agenda you think we should be prioritizing and where there might be gaps. So for those of you participating live, please feel free to answer these questions in the chat and have a discussion with us. Please also feel free to share your contact information in the chat if you'd be interested in contributing to the development and review of this call to action. Finally, I'd just like to say thank you so much to all of the panelists, and we really look forward to continuing this discussion about this exciting topic in the future. Thanks.